This webinar is kindly supported by Convatec and Essity. The supporting companies have not had any influence on the content of the webinar. We hope you will enjoy the webinar.
Good afternoon, everyone, and thank you for joining us. My name is Sebastian Probst. I'm a professor of tissue viability and wound care at the University of Applied Sciences and Arts, Western Switzerland, and the University of Geneva. I am the current president of EWMA. I will be the moderator of this webinar. This webinar is the last episode in a series of 3 webinars focusing on the various aspects of surgical site infections and antimicrobial stewardship. The webinar is based on the EWMA document Surgical Site Infections, Prevention and Management Across Healthcare Sectors, published in 2020. This time, we will focus on epidemiology, prevention and diagnosis of surgical site infections. The webinar will be recorded, so you'll be able to watch it on demand after a few days. You will be able to request a certificate of attendance for the live participation in the webinar if you participate in minimum 70% of the live webinar. A link to the certificate will be sent after the webinar. The 3 speakers will speak approximately 15 minutes. After there will be time for questions. Please note that you can type your question in the Q&A box during the webinar. I am now pleased to introduce the presentations of this webinar and the speakers. I will give the first presentation on post-discharge surveillance of surgical site infections. I will be followed by Leanne Atkin, who is a vascular nurse consultant and lecturer at the University of Huddersfield and Mid-York, NHA's trust. She will talk about surgical site management in the home care sector, organization, and communication. The final speaker will be Karen Uzi, who is a professor and director of Institute of the Skin Integrity and Infection Prevention at the University of Huddersfield. She will speak about antimicrobial stewardship in clinical practice. Please do add any questions you have for each speaker in the questions box and at any time during the presentations, and we will address these after the last presentation. Please add any question, and then we start with the first presentation, which will focus on post-discharge surveillance of surgical site infections. Thank you for joining the talk about post-discharge surveillance of surgical site infections. My name is Sebastian Probst. I am a professor of tissue viability and wound care at the University of Applied Sciences and Arts, Western Switzerland in Geneva, Switzerland, and the University of Geneva. The focus of this presentation is mainly on the home care setting. Surveillance is an important subject not only in the acute care, but also in the home care setting. Early detection, diagnosis and treatment of surgical site infections provides the best opportunities to minimize the associated burden of disease and promote rationalized antibiotic use. However, there are substantial clinical challenges due to the requirement for in-person assessment and the subjective nature of diagnostic criteria. At home, for example, patients have primary responsibility for problem recognition and wound care. A supervised wound assessment and patient-provided communication is missing. So let's see what the literature say about the post-discharge surveillance of surgical site infections. Tonra and colleagues conducted a study where they tried to obtain information from patients' experiences of surgical site infections to improve clinical practice. They conducted narrative interviews with 17 patients with surgical site infections from 3 hospitals in England. Their results show, amongst other elements, that patients lacked overall awareness, concern, and understanding of surgical site infections. 7 patients did not know that they had a surgical site infection, and judging from patients' accounts, staff may contributed to the lack of awareness by informing patients of surgical site infections or downplaying their existence. A comparative descriptive study of 76 patients with wounds by Pieper and colleagues show that the participants' greatest concerns about going home were that they did not know how active they can be at home, what they have to do when they have a wound pain, or what are wound complications, in particular, what are signs of wound infections. Additionally, many participants did not know the dressings or solutions to cleanse the wound at home. Most had taken care of a wound before, could see and reach the wound, and had looked at it during the hospitalization. Patients with acute and chronic wounds did not differ significantly in their concerns about their wound and their fear of taking care of their wound. They generally had appropriate wound knowledge about wounds and had hand washings, nutrition, or going out of the home, and cigarette smoking. They had incorrect information about trying out wounds and leaving them open to breathe at the air. The majority of patients with chronic wounds preferred getting answers to questions about their wounds and its care by their physicians, following by their clinic and family or friends. Horowitz et al. Showed in their evaluation of transitional care from a patient-centered perspective involving 395 participants that 96% of the participants understood the reason they had been in the hospital. Only 60% were able to accurately describe their diagnosis in post-discharge interviews. Discharge instructions routinely included symptoms to watch out for, activity instructions, and diet advice in lay language. However, 27% of the participants reported that the written reasons for their hospitalization was not in a language they could understand. A recent randomized controlled trial by MacLean and colleagues with 492 patients investigates whether a smartphone-delivered wound assessment tool can expedite diagnosis and treatment of surgical site infection after emergency abdominal surgery. This trial has demonstrated that a remote wound follow-up digital intervention increased the likelihood of a surgical site infection being diagnosed within the earlier postoperative period fourfold, although it did not reduce the absolute time to diagnosis of surgical site infections. They also found this was superior to routine care for patients in improving access and perceived quality of care post-discharge while reducing the rate of community care attendance. As we have seen, post-discharge surgical wound infection surveillance is an important part in the care of patients transitioning from the hospital to the home care sector. It is frequently undertaken by patient self-assessment prompted either by a telephone or postal questionnaire. Whitby and colleagues assessed their reliability of the method. They followed 290 patients for 6 weeks postoperatively. Their wounds were photographed and also covertly assessed for signs of infections by 2 experienced infection control nurses. Assessment of photos or signs of infections by the 2 experienced clinicians also correlated poorly with the infection control nurse's diagnosis of infection. The patient's recall for perception of an antibiotic by the general practitioner for wound infection during the postoperative period correlated best with the infection control nurse's diagnosis. So what is important? After discharge from the hospital to the home care setting, the home care nurse needs to apply a holistic care approach in assessment of the patients with wounds in this home care setting. The focus has to be not only on clinical signs of a surgical site infection, but also on the patient's physical, psychological, social, spiritual, and economical needs. Additionally, they have to assess the patient's personal resources and empowerment, the patient's living habits, and possible risks for wound healing or re-ulcerations. So what do we learn from these studies? Healthcare professionals providing home care have to be able to treat, support, and educate patients and informal carers in prevention and management of wounds. A set of minimum skills should be attained. They should have a level of education which enables him or her to work independently under the following circumstances. They have to be able to assess complex wounds and wound healings, to implement wound management based on best practice and evidence, to select best available wound care products in the context of holistic care, and to prevent a surgical site infection. They have to support patients' independence and participation in decision-making. They have to educate patient and informal carers in self-care and wound prevention. Additionally, they have to document the wound healing process, the symptoms and treatments of wounds, as well as patients and informal carers' concordance with care. They have to ensure the continuity of care in all circumstances or conditions, and to integrate a multi-professional knowledge for a patient care by using consultation and e-health. In conclusion, we can say that surgical site infections are an important healthcare associated complication, also in the home care sector, with the potential to be prevented in some cases. They exert a considerable effect on patient morbidity, mortality, and quality of life. Early detection of surgical site infections is crucial to reduce the severity and duration of infection. A post-discharge photo, for example, provides our patients and carers with a practical, simple tool for use between acute and community care, and provides an ambiguous baseline as to whether the surgical wound is improving or deteriorating, and a legible, documented full assessment of the surgical wound. Thank you very much for joining, and I look forward for your questions. I am now pleased to hand over to the second speaker, Leanne Atkins, and she will talk about surgical site infection management in the home care sector, organization, and communication. And please don't forget to write your questions in the Q&A section. Please, Leanne.
Hi everybody, I hope you can see my screen and I hope you can hear me okay. It's my pleasure to be here this afternoon. My name is Leanne Atkin. I'm a vascular nurse consultant at Mid York's NHS Trust, which is up in Yorkshire within the UK, and I'm also a research fellow at the University of Huddersfield working with Professor Uzi. So my session today is around surgical site infection management in the home care sector and how the challenges that this sector specifically raises in terms of the organisation and the communication of surgical site infection and the management of these patients. So I think it's really important to understand the total burden. Sebastian's already explained to you the national burden that's happening across Europe. But I think these figures from the NHS are really important in terms of when you look at the overall burden of wounds that the NHS is dealing with, 14% of them are surgical wounds. And as we know, a surgical site infection is a common healthcare associated infection in surgical wounds. And these infections have significant consequences for the patient, but are also the most expensive health associated infection in terms of use of resources. And it's said within the UK that the cost of managing a patient with a surgical site infection is 3 times greater than if they didn't get an infection. And the estimated cost per patient with a surgical site infection raises to £8,500 per patient, which is a significant spend per patient for the NHS. And the most worrying thing about these factors is, as already explained, the number of SSIs out there in community is probably underreported. So the economic burden is also probably underestimated. And there are links in terms of issues with the overuse of antibiotics, and Professor Uzi will be talking about this in more detail. And there's a growing risk of litigation from our patients if they feel that there was an element of harm or neglect that's actually caused that surgical site infection. So I think that this session really that we're talking about today cannot forget the actual focus needs to be on the prevention of the SSI. And we need to be really focused and have clear methodologies of how we treat patients in the pre-operative and intraoperative period. So there is a range of documents out there that help actually give clinicians that true guidance of what is the evidence base and what should we be doing to ensure that we reduce the risk of surgical site infection for our patients. We're here this evening to talk about the relatively new EWMA document on surgical site infections, which covers these stages. But it also has a significant chapter on what do we do post-operatively to help to reduce the chance of a surgical site infection. And this document spells out a few key points that I just want to really talk about what challenges are faced by delivering these within healthcare resources, especially thinking about community services. So the first of their points is that we should cover the wound with a protective dressing for at least 48 hours, and that wound dressings are seen as their overall post-operative management of the wound. Now, I understand the need for this, but I think as well that we have to recognise that for the majority of our patients, they have a wound dressing that comes out of theatre in a type of non-woven dressing. We still, even though the evidence is growing, we still have an underuse of specific post-operative dressings, such as films and pads. And actually, it's not just about getting the protective dressing in place of 48 hours. It's about choosing the right dressing for that patient at that point in their journey. Because unfortunately, we still have issues with post-operative blistering following the use of simple woven pads. So the focus has to be to try to protect that dressing for 48 hours, but also ensure that that dressing that's applied in that theatre environment is actually fit for purpose. We understand out there at this moment that there is a lot of choice when it comes to post-operative dressing, and even though there is some emerging evidence, there still needs to be more clear evidence. And I understand that actually many organisations are trying to balance the cost versus the evidence. But I really think that we need to be thinking about increasing the level of evidence and the availability of the more technology-based dressings for our patients, because we all understand the issue when it comes to simple woven cotton dressing. The other thing that the EWMA document asks us to consider within management of patients within the community is actually really focusing on that management of those patient-related factors. And I think that this is really where the community teams really need to understand how the relationship between those patient-related factors and that risk of surgical site infection is directly linked. I'm a vascular clinician, and this unfortunately is the typical caricature of the patients that we are operating on. And we need to actually have an individualised risk assessment for each of our patients, thinking about their demographics, their underlying disease, their past medical history. What is their anaesthetic risk? Because we know the higher your anaesthetic risk, the more likely you are to get a surgical site infection. We need to be really thinking about careful inspection and really close management of any patient that's had any form of dirty surgery or that's got any ischemia in the wound, especially if underlying those wounds is any evidence of prosthetic material. Because once prosthetic material gets infected and covered with biofilm, the outcomes for the patients is significant. But within vascular especially, I think that we need to have a good consideration about a patient's BMI, especially the risk of breakdown for things like groin surgery, which can be prolific and high in prevalence. And we need to be thinking of the generalised condition of the skin. And I think this is one place where the community nursing teams can really help. Because if you've got a patient that's facing surgery, we can talk about optimisation of that skin earlier on in that pathway, rather than thinking of just managing those factors post-operatively. But the one thing that I think is the greatest challenge is the use of the anti-aseptic technique at all time within a community setting. And I say this because I understand the difficulties that community nurses are facing. Unfortunately, we do not work in sterile clinic environments. We work in areas where the bath isn't used for bathing. We work, and if you can see in that picture, there's a bicycle positioned in front of the sink. We work in areas where you can't actually reach the sink to be able to wash your hands before treating these patients because it's covered in clutter. We work in crowded environments where there is actually no room to lay an aseptic field. And actually in places where generalised hygiene is a huge issue, never mind the use of an aseptic technique. And my favourite one of all, which I think is the greatest of challenge, is how do you maintain an aseptic technique when the dog wants to join you in on the dressing changes? And these are the common factors that community nurses are facing. And we need a whole armoury of tools in our toolbox to be able to cope and to be able to challenge to ensure that we are providing the best care we can for our patients. I think one of the recommendations from this guideline is really challenging in terms of patients should be seen by healthcare professionals with tissue viability experience and expertise. And I'm very glad that you're joining us today to help to increase your level of knowledge in this area. I think this is a great challenge because actually in a community setting, patients with a wound is seen by a huge variety of clinicians, which some may have some wound experience and expertise and others that may not. And because nobody owns the space of wound care, ensuring that we have a competent and capable workforce can be a significant challenge, especially out in the community setting. And this lack of wound care ownership actually means that majority of the patients out there are seen by generalist nurses. Only 1% within the UK of the wound population actually has had any involvement from a specialist nurse. And only 17% have been seen in specialist wound care clinics. So we need to think about increasing the number of nurse prescribers with an expertise in wound care. We need to be thinking about getting quicker escalation for these patients if they are failing, and an increased amount of input from our medical teams. I think it's really important that anybody that's dealing with surgical site infections are able to distinguish between what is a wound dehiscence and what are the causes for that. Because we're talking tonight about surgical site infection, but there's many other reasons why wound dehiscence can occur. And it is vital that these patients are seen by a person with some experience and expertise in wound care to be able to tease out these factors. Because actually a surgical dehiscence can be directly linked to the use of antibiotics. And as Karen will explain in a little while, sometimes that is not needed, in fact, could be damaging. Within the UK at this moment in time, around 50% of all wounds out there which have been treated as a surgical site infection have had at least one course of oral antibiotics prescribed. And you do have to question, was every single prescription for those ultimately needed? Or is actually there is a credible AMS risk, which I believe that there is. I think the global pandemic has really told us what it's like to live with a disease or a virus or an infection where there is no known cause. And actually, if you think the pandemic is bad, just imagine a world where we have got complete antimicrobial resistance. Patients will be dying of infections much more commonly than what they are currently dying from coronavirus. So antibiotic resistance is a real issue. But I just want to spend the last 5 minutes of my talk talking about why is this so important? Why is surgical site infections so in need of our investment of education and our focus? And the main thing about that is actually it's the impact of the patient. Imagine yourself going into theatre. You would never anticipate that your wound is going to break down. You'd anticipate you're going to get a surgical wound. It's going to be close together by one form or another, and you would imagine wound healing to occur. And when you look at the evidence of patients, what they talk about is they talk about absolute shock, disbelief, unexpected, and the alarm. And living with a chronic wound that's not healing, we know has significant psychological and physical impacts. It really gives them a feeling of frustration, powerless, guilt, debilitation. And many patients have unrealistic hopes of healing time. We really need to focus on that prevention to stop this patient's suffering. Because the true consequence of a surgical site infection is more than just a wound. If you've had an arterial bypass graft and your wound starts to break down, that graft needs to be removed, and therefore you are at risk of losing your leg. If you have a significant injury of graft infection in your groin, you could be facing a hind quarter amputation. If your grafts start to protrude from an axilla bifem graft, you could look at actually losing both of your lower limbs. Or if you are that patient who's finally committed to having their leg removed and their wound starts to break down, your thoughts of being in a wheelchair for 3 or 4 months until you get your prosthetic starts to increase more likely to 6 to 12 months, if forever. And this is the true consequence of surgical site infection, and that's why this type of education is so vital. We need to focus on the prevention, and the best way to do that is actually to agree and to provide those national standards. It's providing those surgical site care bundles, it's using that standardised infection control precaution and using those true evidence-based surgical site infection interventions, just like highlighted within the EWMA document. We need a capable workforce, somebody that's able to recognise the difference between dehiscence and infection. We need to be able to think about when do we need local treatments, when do we need systemic treatments, and people to be aware of the need for direct communication and escalation of these patients. I think communication is key. This document talks about informing the community nurse prior to discharging that patient. I think as well we need to be talking about the communication from that community team going back to the surgical team. Because if the surgical team is not aware of this surgical site infection, how on earth can they do a degree of self-reflection, audit, quality improvement? We know quality improvement is actually what's needed in this space. We need to be thinking about whole system changes to help to improve every patient outcome. I love this quote. I believe that every system is perfectly designed to get the results it achieves. So actually, if we are getting surgical site infection, there is something wrong in the design of the system. And ensuring that clinician knows about that surgical site infection then allows that quality improvement framework to be put into place. So thanks for listening. I hope you've enjoyed this session, and we'll be asking questions at the end. Many thanks.
Thank you very much for the presentation, Leanne. Please don't forget to put your questions in the Q&A section. I am now pleased to welcome Professor Karen Uzi, and she will talk about antimicrobial stewardship in clinical practice. Please, Karen.
Oh, thank you, Sebastian. Yes, I've just remembered to come off mute. So hopefully you can see my screen now. And thank you to Sebastian and Leanne for those excellent presentations. And Leanne, thank you for setting the scene about antimicrobial stewardship. And as you all know, it's something I'm very, very passionate about at the moment. I want to try and highlight how important it is to be a priority to everybody. So first of all, I just want to think about what is antimicrobial resistance before we talk about antimicrobial stewardship. And this happens when the bugs become superbugs, if you like, so they become resistant to everything that we literally throw at them. And it's not new, antimicrobial resistance at all. The World Health Organization has been identifying it as a risk for many, many years. And they've published lots and lots of work on it. And I'm going to share some of the newest work very shortly. But when it comes to wounds, this is something we really need to be thinking about. And in the past, we've thought about antibiotic resistance, and everybody's very much aware about using antibiotics. But we've forgotten about our antifungals, antiparasites, and also antimicrobial wound dressings. So we must remember that wounds are a source of infection. They're a break in the integrity of the skin, and therefore we're risking them becoming infected. And it is a global problem, antimicrobial resistance. Please don't think it's just something in one country. It really does affect everybody. And this rising spread of antimicrobial resistance is now creating this new generation of superbugs. And we've talked about superbugs for many years, but I don't think we've really taken it that seriously. We've always thought, be absolutely fine, we'll manage, we've got lots and lots of antibiotics, antimicrobials in our arsenal. But if we leave the effects of AMR unchecked, it's going to become more wide-ranging, costly, but not only costly in financial terms, but in terms of the health, global health, food sustainability, well-being and socio-economic development. And I think Leanne showed that quite nicely when she showed the slide about how many antibiotics we use in wound care and the effects of what happens if wounds break down. And at the moment, just to put it in context, AMR infections are estimated to cause approximately 700,000 deaths each year globally. So think about what we're talking about with the pandemic at the moment caused by COVID, and then look at those numbers as well for AMR. And that figure is predicted to rise as well. So it's not only a cost to the quality of life of the patient, but also a financial cost for us. and I really like this slide. If we don't start doing something actively now to prevent antimicrobial resistance, by 2050, we're going to have an excess of 10 million deaths, which is going to cost £66 trillion. This is absolutely huge. And more scarily than that, we've had no new class of antibiotic since the 1980s. So we're relying on very old antibiotics that these bugs have become so clever to being resistant to. The scientists globally are trying to develop new antibiotics, so please don't panic too much. However, we do need to panic. They're not there at the moment. And you can see from this slide that the AMR deaths by 2050, if we don't do something, are going to be in excess of the deaths caused by cancer and diabetes and road traffic accidents. So I do think that puts it into context why we need to start acting now and not just think we're going to be absolutely fine. So there's lots of documents out there. The Global Alliance in Surgery has published their post-COVID recommendations. The World Health Organization has published many recommendations about managing AMR, as has the European Commission and also NHS England and NHS Scotland and Wales. However, what we need to be thinking about is how do we manage this? And one of the ways to manage it is antimicrobial stewardship. And this is obviously a component of a multifaceted approach to preventing AMR, but it's something that we can all be a part of. And good antimicrobial stewardship involves selecting an appropriate drug. Is it an appropriate antibiotic? Is it appropriate antifungal? Is it an appropriate antimicrobial dressing? We should ensure that we optimize the dose and duration, so to ensure that we're managing the infection at that time now. And that means keep reviewing the wound. So prescribe your antibiotics for maybe 5 days, then ask the patient to come back and see you and review the wound again to see whether or not it's still infected. And try and not give patients repeat prescriptions, because if you do, they'll keep going to the pharmacist and getting antibiotics week on week, month on month. And then we often go and see patients who say, oh, I've been on flucloxacillin for the last 2 years. That's not good. That's really helping antimicrobial resistance. So good antimicrobial stewardship includes that continuing review of the need for antibiotics and the continuing review for the need for antimicrobial antimicrobial wound dressings. So I want to remind you as well that when you go and assess your wound assessment is essential. Is it infected or is it inflamed? Is it contaminated or colonized? So being able to understand what wound infection is and to not be using antimicrobial dressings for that just in case scenario. And by that, I mean, just in case it becomes infected. We don't need to be doing that. We need to be managing wounds appropriately after our assessment, but also, of course, implementing antibiofilm strategies if necessary. But the World Health Organization has been excellent in the support that it gives to us as practitioners. And here they have a document, Antimicrobial Stewardship Interventions, a Practical Guide. And it's worth going having a look at this. It quite clearly highlights what we should be doing and how we should be managing it. But we also need to look at these barriers that may be there in antimicrobial stewardship. And that includes clinicians' knowledge deficits and also patients and carers as well. We have to ensure that we educate everybody about what AMR is and what AMS is, and trying to say to people, we're not stopping you from having an antimicrobial. What we're doing is ensuring we've got efficient and effective use of them. We sometimes see opposition from clinicians to antimicrobial stewardship because sometimes they don't understand what we're trying to do. Again, we're not trying to stop people use antimicrobials. We're saying, look at the wound. Is it infected? Does the patient have an infection? And sometimes we've got limited access to reliable clinical diagnostics and microbiological testing, which can help us understand whether or not this is an infection. If it is, which antibiotics are required. and limited access to data. And I think both Sebastian and Leanne have talked about this, that we need good metrics and good data. We have to be documenting when a patient has an infection, what type of infection, and is there some way of being able to track that infection back? Is it due to poor surgical technique, incorrect wound assessment, or is it because patients are living in homes like Leanne has shown you, which are maybe not quite as clean as we would expect them to be? And one of the most important things is trying to get over this limited or lack of communication between healthcare providers. We have to ensure we have clear communication strategies, and that means being both speaking verbally to each other, but documenting what we say as well. Because I may speak to you today about the wound assessment that I've undertaken and why I don't think it needs an antimicrobial, and you're quite happy with that. But the person that goes to see that patient maybe in 4 days' time hasn't spoken to me, doesn't know what we've discussed, and if we haven't written it down, then they start again from the beginning and may change the treatment plan because of lack of understanding. So when we're implementing antimicrobial stewardship into clinical practice, clearly we need good communication strategies. Antibiotic lists are good. So that means including the multidisciplinary team, which very much includes pharmacy, who can say, these are the antibiotics we recommend you use as long as you've undertaken your correct wound swabs or wound biopsies. Local guides for diagnostics of infections, that people can have a look at these guides and understand what they need to do. And local guides for initial antimicrobial therapy. And I say local because you'll have your local guidance, policies and procedures that you must follow, as well as looking at international guidance. But communication really is key to this. Communicating with our fellow professionals, but also patients. Within England, we have Public Health England, and in 2015, so this is 6 years ago, they were publishing pathways for antimicrobial stewardship. And you can see here these Start Smart, then Focus tools, which clearly shows us what we should be doing from theatre out into the community as well. So it's not new, but for some reason, this seems to have been overlooked. Within your own countries as well, your health providers will have provided these as well. So go and have a look and see what's there, because there's no point in reinventing the wheel if there's some pathways and algorithms there that you can share with staff to be able to educate people and also to be able to follow for your own practice. The World Health Organization has published these 2 documents. So health workers education training on antimicrobial resistance, complemented by competency frameworks, free to download from the World Health Organization. This is a global document that helps us build on the knowledge that we already have and raising our awareness of antimicrobial resistance. It also talks about appropriate use of antimicrobial agents and how we prevent and control infection. It also explains really clearly about diagnostic stewardship and surveillance, and talks about ethical implications, but also leadership, communication, governance strategies that we can use. So we have lots and lots of education strategies we can draw upon. But the crisis is here already, sadly, and antimicrobial resistance is the new pandemic. We should ensure that results from our microbiological investigations inform the choice of antibiotic therapy. So we're very focused and we're targeted. We have a scoring system for where wounds and patients' clinical state should inform the choice of antibiotic. And it's important to choose those antibiotics and antimicrobials that actually work. We should consider combinations of antibiotics as well, but also consider the impact of biofilm. We must get rid of that biofilm and clean the wound bed properly before we start thinking about antimicrobials that we use in a timely and optimal way. So training of health and social care workers, such as hand hygiene and aseptic or clean techniques, has actually been raised during the pandemic. Healthcare professionals knew quite clearly how to wash their hands pre-pandemic, But I think the general public now are more aware about how good it is to wash your hands properly for 20 seconds. We need to ensure that we use surveillance systems to recognise infections, and also to ensure that we have good metrics to be able to measure any interventions we use and how good they've been against antimicrobial resistance. We need vaccination of healthcare workers to protect patients from spread in healthcare settings, but we must ensure that we decontaminate medical devices or use a once-only medical device. And environmental cleaning is essential. And I think that was really highlighted in Leanne's presentation, where she showed people's own homes. So again, the importance of washing hands there. So antimicrobial stewardship programs are interprofessional. It's not just about one professional group, it's everybody's responsibility. We have to minimize unnecessary use of antimicrobials, and we have to ensure that we employ the expertise of tissue viability, infection prevention, microbiology, and also the general public. So it must be an interprofessional approach to this. And this publication here by Lipsky and his team is excellent. It's published in the Journal of Antimicrobial Chemotherapy in association with the European Wound Management Association, and it highlights antimicrobial stewardship in wound care. And it's the first position paper that's been written. So please do have a look at this, because there's some really good pathways in there as well. And the whole aim of the paper is to use inappropriate use of antimicrobials by promoting, facilitating and teaching good antimicrobial practice. So please do have a look at this if you haven't already done so. And if you're now very excited about antimicrobial resistance and you want to prevent it, and you want to know more about antimicrobial stewardship, there's this free online course. It's on the Future Learn website, and the link is here in front of you. Should probably take you no longer than 9 hours to complete. And it talks about what infection is, what wound infection is, what antimicrobial resistance is, what antimicrobial stewardship, and then it's all tied together through real life case studies. There's lots of forums on there when you can talk to other healthcare professionals and you can share knowledge. But if you really do want to learn more about this, please do log on to it, and it's a really enjoyable course. Here's your references. And again, thank you very much for listening, and I look forward to any questions. Thank you.
Thank you very much, Karen, for your presentation. We will now move on to the questions from the audience. And one of the questions is, is there any evidence that antimicrobial dressings causes antimicrobial resistance?
Sebastian, no, not particularly. It's all about using them effectively. And there's not, the antimicrobials we use, they're actually quite a small amount of antimicrobial in there, but we can't just be using for that just in case scenario. Otherwise, every patient we see will have an antimicrobial put on them. But what we do need to think about is antibiofilm strategies as well. So using your antibiofilm strategies when you want to clean that wound bed up, but then stopping it when the wound bed is clean. So it's about taking a really good overview of what you want to do when you're assessing your wound.
Thank you, Karen. Another question is, how do we get AMS recognized as a priority?
Oh, I'd love it to be, Sebastian. And I think everybody should think about AMS every day, every evening. But I think it's about webinars like this that highlight the importance, but also it's about healthcare professionals recognizing antimicrobial resistance, and that it's not something that's going to happen in 50 years' time. It's happening now. And I think when the slide that I put up that shows that we've had no new antibiotics since the 1980s really puts that into perspective, but also the excess deaths. And it's giving these statistics out to people to say, we're not saying this because we feel like saying it, we're saying it because there is a real issue. And Leanne and you showed excellent slides about managing surgical site infection. If we don't manage antimicrobial resistance first, then we're going to have surgical site infection all the time because we're going to have nothing to manage it with.
For me, I think it needs to be everybody's business, everybody who's dealing with any type of patient, or in fact anybody, because a lot of farmers use antibiotics. We need it to be everybody's business, and everybody needs to think about this. And I think that's one thing that the pandemic has really brought home to us, is what it's like to treat something without a known therapy. You can imagine the future now of being able to treat any infections without a known therapy, thanks to the COVID. So I think it needs to be everybody's businesses, and I think it needs to be multi-approach. So I think when any talks that me and Karen deliver these days, we always mention AMR and AMS, and it's about us all just trying to take it out there. For anybody that's a user of antimicrobials, antiseptics, or antibiotics, or antibiocides, the need to have that greater awareness of the impact of their own individual actions could have on the bigger picture out there.
Leanne, also, I think it's about, we often talk about healthcare professionals and raising their understanding and knowledge, but it's getting it out to the general public as well. About
absolutely.
Hand washing that we've done throughout the pandemic and still doing now, hopefully, but also that sometimes people will go and see the general practitioner or go and see the surgeon and say, I want one of those magic tablets that kills it. I've got a cough, therefore I need an antibiotic, or my wound looks red, therefore I need one of those special dressings that you give me that have silver in, for example. So it's about educating the patient to say when you do and don't need antibiotics, and really how to recognise when a wound is infected so you don't need a magic dressing. It's not us that's being awful or mean or horrible. We're actually trying to help everybody's health.
And I think that you're right. And, the campaign that's happened, especially in the UK, about coughs and colds is a virus, wait 5 to 7 days, don't escalate it. This is all prior to COVID, was making an impact on the number of antibiotics that were given out for ear infections, throat infections, and generalized cold. But we haven't made any movement in terms of my legs are red. We know that 50% of cellulitis diagnosis isn't cellulitis, it's probably venous insufficiency or lymphatic inflammation that you're seeing. And I think Karen's right. I think there needs to be a whole public awareness campaign about what is a wound infection, what turns legs red, because there's a number of things, and it's the same as the surgical site infection breakdown. There are many reasons why wound dehiscence occurs. Infection is only one of those, and we need people out there to be able to get the messages out that there is many other reasons why a surgical wound breaks down.
I think you make a very, very important point, that we have to have good educated healthcare staff that recognizes the signs early. And Karen, you said something very important, that we have to educate the patients. We have to tell them what to do and what not to do. During your presentation, Leanne, you were talking about the surgical site infection care bundles. Can you say something more about this?
So the use of care bundles is quite widespread within the UK. We use care bundles for many things, and it's all about that risk mitigation. And I love the slides that anybody who presents about risk does. That, if you imagine a piece of Edam cheese, if you've got multiple layers of Edam cheese, it's very unlikely you're going to be able to put your finger through it. But actually, at times, if your Edam cheese lines up perfectly, you can get your finger through it. And the idea of a care bundle is that you put a break in multiple places to actually stop something from happening. So the care bundle has to work across the whole of the perioperative journey of that patient, and it has to take into account every single aspect of that care. This document that's been produced by EWMA really spells out of what are those important aspects. There's some big ones: hand washing, dressing, not touching it for 48 hours, some big ones, but there's some little ones that's as important. Maintaining the temperature of the patient whilst they're in an operating environment is a really key consideration of reducing surgical site infections. So it's about ensuring that we have a safety check, that we have all of that care in place for that patient, because that's the best way to reduce the risk of harm.
Leanne, I also think, sorry, Sebastian, that it's about the communication is so key, because I think patients come in hospital, we're very good at preparing them for their surgery. They have it, they come back to the ward, and we're all very happy and check everything. Then the patient goes home and we think we can forget about them now. So it ends up in somebody else's, like you say, in the care environment without actually feeding back. So we have a very good mechanism of feeding that way, like you said, but it doesn't come back this way. So that's then very much about getting your general practitioners involved and your practice nurses who work with the general practitioners, not just your district nurses and your community nurses, and pharmacy as well. Because often you'll go to the pharmacy and say, oh, it's a bit red, a bit itchy, give me something for it. But then in a hospital, they never know any of that. So that's key as well.
Completely. And you know, I do think if we had a real accurate reflection of the data across the whole environment, there would have been more investment in terms of all of this education and resource that we need. I think the issue is that most of these fall silent. You know, once the discharge from the patient, we very routinely now, we very rarely now see patients just to see, or a wound check, or a just in case. So, you know, you can have quite extensive surgery these days and you'll never see that clinician again who's operated on you. Well, you know, that clinician may have a huge gap in their knowledge or their practice that they may need updating, but we've got no reporting mechanism for that to come back to that individual. You know, we have mechanisms in place for mortality. We have mechanisms in place if you get a DVT post-operatively. We've got a mechanism in place if you get a pressure ulcer on discharge. Why haven't we got mechanisms in place for surgical site infections to be reported back? You know, and I think that's a challenge to us at our level, that we really need to be pushing for that if we're ever going to make a difference.
So thank you very much, both of you, for this very nice discussion. And I would like to come slowly to an end. And don't forget, you will be able to access the video recording of the webinar on demand via the EWMA website within a few days. We hope that you will join us for one of our next webinars. In January 22, you can join a webinar on infection, clinical dilemmas in the management of the diabetic foot. This webinar will be held in collaboration with BSAC on the 20th of January 22. In January, you can also join the first webinar on the science and the practice of skin tears, held on the 21st of January 22. This is the first in a series of 2 webinars held by ISTAP and EWMA. You can keep yourself posted about future EWMA webinars via the EWMA newsletter, our social media, or website. Finally, we hope to see you all at the next EWMA conference in Paris from the 1st to the 3rd of February 22. Thank you again. Stay safe and have a good evening. Bye-bye.